Okay, we shall begin talking about bacterial infectious illnesses. We're going to talk about MRSA, scarlet fever, pertussis, and impetigo. Okay, so methicillin-resistant Staphylococcus aureus is usually community acquired. That's the pathology of this. The bacteria gets into the skin through a cut, an abrasion, or a lesion, or just really dry skin. It's transmissible through contact, through respiratory droplets, blood. It can linger on surfaces for quite a long time, um, and heat doesn't really kill it, so it can be there even in the summer. And it can stay on personal items like hairbrushes. The cues are a red, swollen, painful, what we call fluctuant abscess. So fluctuant means if you can think of like something that seems like it probably has fluid in it. Um, Gooey. It often starts in the hair follicles on adults, like groin or axillary, or it starts out like a pimple type papule or vesicle. So for little ones, we see MRSA transmitted a lot into the diaper region because parents are changing the diapers and they see like a little pimply looking skin change, and it could be something very benign, but then the parents pick at it. Just like I'm sure every one of you guys that has ever had a child who has little baby acne, we tend to really have to fight our desire to pick that. And so our filthy fingernails, despite how clean we might think they are, is what is usually transmitting the MRSA into the diaper region or the skin of a little one. So we diagnose only with culture. So if the abscess has not opened, if there's no drainage or fluid or pus, then we can only say that it's cellulitis or a boil. We can't say that it's MRSA, but usually we're going to treat it presumptively like MRSA regardless. The management with antibiotics is usually either Vanco or Clinda, and nursing actions include controlling pain with warm compresses. We'll usually have an order or we'll ask for an order to use warm compresses, TID, and we will crack the little baby heel warmers and put that on the lesions or stuff it into the diaper because we see a lot of this, like I said, in diaper regions. We can give pain meds, and we should be nice and give those around the clock. We're going to educate families about hygiene and completing antibiotic therapy, not sharing personal items, and maintaining contact precautions. It is very difficult to manage these areas of abscess in an infant or small child like a toddler or a preschooler because, like I said, we do get a lot of it in the diaper region. And I have seen like little 3-month-old, 6-month-old labia with cellulitis. It triples, quadruples in size, and then we have to cut it open and pack it filled with the like iodoform gauze that's been treated and cover it with Tegaderm and try to keep it clean. And if you can imagine a diaper region and how difficult that is to keep clean, it's challenging. So we are also going to make sure that we do really good contact precautions. One of the things that one of the hospitalists that I really enjoyed from Memorial back in the good old days was he would tell families to treat everyone in the family once a week while a child had an outbreak or anyone in the house had an outbreak, to treat everyone in the family once a week by bathing in a bath with normal bath water, but putting 3 capfuls of betadine into the bathtub. And that's really cheap and it's really easy. And then he would tell them to get Vaseline and to coat the inside of everyone in the house's nasal passages with Vaseline and blow their nose real good at the beginning and end of the day to get all the Vaseline out, and then do it again. And that's going to help to kind of contain the spread of it through the household. Okay, scarlet fever. Scarlet fever is caused by group A beta hemolytic strep, which is why I included a little toothbrush on the picture, because just like strep throat, we need whoever might have scarlet fever to throw away their toothbrush after 24 hours of antibiotic therapy. Scarlet fever is something that happens usually a few days to a few weeks after exposure to a strep virus or strep bacteria. So, strep throat, impetigo, any strep infection on the skin, and scarlet fever can happen. So the risk factor is children between the ages of 5 and 15 years. They tend to get high fevers greater than 101 with chills, nausea, vomiting, and body aches. They also get this red erythematous rash that worsens whenever they're crying or they have a temperature. It looks like a sunburn, but when you touch it, it feels like sandpaper. Usually the palms of the hands and the soles of the feet do not have this sandpaper rash. We treat scarlet fever with penicillin or amoxicillin. If the person has a psyllin allergy, we will give them erythromycin. And then our actions for nursing is going to be providing comfort measures. We're going to increase their fluid any way we can. Popsicles, soups. We're going to use humidifiers. We're going to make sure that they practice good oral hygiene. We're going to do strict I's and O's. Most of the time, these kids are going to be managed at home unless they have some complications related to the scarlet fever, but usually they don't. So just know that it is a highly contagious respiratory illness that is related to having had a group A strep infection. Pertussis is an acute respiratory disorder caused by the bacteria Bordetella pertussis. The risk factors, it's worse for children who are under a year old, and that's because of the size of their airways. So pertussis is also called whooping cough. These children will have a characteristic paroxysmal cough. So the cough can last anywhere from 10 seconds to a few minutes, and they have a really weird whoop sound that happens when they try to breathe in. They have lots and lots and lots of secretions, so tons of mucus, tons of nasal secretion. The highest incidence and greatest risk for severe disease and death is in children younger than a year old. So every single person who gives birth should make sure, because you cannot be fully immunized with your DTaP, um, before you're 5 years old. So every person should be making sure that every family member or caregiver or care provider, whoever, babysitters, is updated with their whooping cough vaccine. Um, Otherwise, they shouldn't be touching your children. The incubation period is 6 to 21 days. Usually it's around 7 to 10. And there's about 7 to 10 days of cold symptoms, and this is when it's incubating. And then the coughing spells start, and that can last anywhere from 1 to 4 weeks. And then they start to get a little better after a full month of having coughing fits so bad they usually need oxygen. And some babies have been intubated because of it. After that, they can have a period of convalescence, and that period of convalescence can be months and months long. So pertussis can make these little ones really sick for a really long time. For a while, immunization rates really decreased the incidence of pertussis, but ever since about the mid 1990s, there's been an increase in pertussis cases, especially in adolescents and adults. So what that means is that those adolescents and adults are now able to spread it to our little tiny ones because they are not getting either fully immunized, or they're not receiving their boosters, or they just don't care. Let me see. So we have seen such a high rise in the amount of pertussis cases in adolescents and adults that we are requiring everyone upwards of 11 years old, I believe, has to have one booster of Tdap. The management for this is erythromycin, clarithromycin. If it's a little, we usually give azithromycin. And the actions that we're going to take as nurses is providing high humidity environments, frequent suctioning and maintaining their airway, and providing oxygenation. The complications of pertussis are hypoxia, apnea, pneumonia, seizures, encephalopathy, and death. Impetigo. This, just like scarlet fever and strep throat, is caused by group A beta hemolytic strep. It can also be caused by Staph aureus. So the risk factors are a child, because they're always touching their faces with their grody little fingers, and maybe they have really dry skin or a really runny nose, or they've been ill recently with a cold, and they've got some broken skin up or around the mouth or nose. So at this point, they are infecting themselves with the strep or the Staph aureus, and it's going to create this signature honey-colored crust. Just makes you want to go have some honey. So this honey-colored crust is going to be on the papules that show up around the mouth, the nose, the ears, the cheeks, wherever the infection got in. And basically what I attribute this honey-colored crust to is that the toxins that break down from the dead pathogen, regardless of whether it's group A strep or Staph aureus, it breaks down and leaches through the skin. So this is like the leftover poopy decomposing bacterial matter on the skin. It's so gross. It's highly contagious. Usually it's diagnosed visually, but I believe they can take scrapings of the crust to get to the fluid underneath, and they would look at it under a microscope and see what it was. Um, we give topical antibiotics. If it's really severe or it's not going away, we'll provide oral antibiotics. The same ones that you would treat scarlet fever with, the same ones that you might treat strep throat with. And then our actions, or how we're going to educate the parents, is that they're going to apply cool, wet compresses to the region 2 to 3 times a day. And they're going to keep the cool, wet compress on there long enough to soak the crust. And then they're going to kind of debride it off. And then they can apply the antibiotic ointment. It doesn't do any good to apply the ointment on top of this crust because you're basically just slapping ointment all over hardened poop, basically. So we need to get the poopy stuff off of there so that we can actually get to the live bacteria, which is underneath. Gross, right? So yay, that's impetigo.